Good morning. As most of you are aware, my office has spent the better part of a year examining the issues that are impacting rural hospitals as we strive to create a system of sustainability that takes care of the newly enhanced Medicaid population and all our people in rural Kentucky. Folks, this is important because our rural hospitals exist as one of the fundamental pillars of economic growth and quality of life in every community they serve. So before we get into what this report is about, let's start with what it is not about. It's not a rebuke of managed care, Medicaid expansion, Connect, or the Affordable Care Act. It doesn't dispute that expansion has had an overall positive economic impact on Kentucky, has resulted in a net gain of jobs, and most importantly, has expanded access to health care to nearly 400,000 Kentuckians. All of this should create a healthier Commonwealth. What this report is about is making sure that in rural Kentucky, the newly insured and those who already had coverage have adequate access to health care as the health care landscape undergoes a rapid and challenging transformation. The landscape has already shifted dramatically as a result of many factors, ranging from a poor economic climate to rapidly changing expensive technological advances, new and costly health record mandates, and of course, Medicare managed care, Medicaid managed care, Medicaid expansion, and the Affordable Care Act. Additional changes are on the horizon, including scheduled reductions in Medicaid disproportionate share, or DISH payments, and continued cuts in Medicare fee-for-service programs. The importance of rural hospitals cannot be understated. They provide health care to 45% of Kentuckians. In every community they serve, they act as one of the larger employers, paying a significantly higher average than higher wage than the average community experiences. In many rural communities in particular, these hospitals are the first or second largest employer. They generate a tremendous amount of economic activity in their respective communities and state, as well as a significant amount of state and local tax revenue. They also establish themselves as a precondition for economic growth. Folks, people do not put factories in communities where someone hurt on the line can't be stitched up quickly. This report provides an overview of the economic challenges facing these hospitals and makes recommendations to help them through this difficult transition period. The results are designed to provide policymakers with a baseline for monitoring the financial strength of these rural hospitals going forward. Policymakers and local communities should not be caught off guard by the closing of a hospital, as we were recently with the announcement that the Fulton County Hospital was shutting its doors and laying off nearly 200 employees. The layoffs and loss of wages being spent in that community are bad enough, but the Fulton city manager told the press that the taxes Parkway Regional Hospital pays amount to 18% of city revenue. This is an economic spiral. The hope with this report is to establish a baseline for analysis beyond the vagaries of rhetoric, because refusing to drill down robs stakeholders of the information they need to guide this transformation. Although closure may be an unfortunate reality for some, I believe more can and should be done to help these hospitals rethink their models of business and delivering health care in the 21st century. The results of this analysis are designed to provide policymakers and hospital administrators with information that may be used to affect changes in laws, regulations, and policies that affect the financial well-being of our rural hospitals. The primary focus of this report was utilizing a proprietary formula called the Financial Strength Index, or FSI, to assess the financial strength of 44 rural hospitals or systems that agreed to participate in our study. The FSI considers the total margin, which is the percentage of revenue kept as profit, days of cash on hand, depreciation, and debt financing. I can tell you that these are the four guide marks that almost any business would use to evaluate their own financial strength. We also surveyed rural hospital administrators, held 11 public hearings across Kentucky, met with representatives of all 5 managed care organizations, and analyzed ad hoc reports about provider types. So what did we find? Now keep in mind the Financial Strength Index was limited to running through the first year of managed care in Kentucky, but does not fully consider the implementation of the Affordable Care Act. and Medicaid expansion in Kentucky. That's simply because we don't yet have 2014 audited financials to rely upon. And what makes me different from other elected officials in Kentucky is I'm not in a position to offer an opinion or advice or good counsel based on anything other but firm numbers, and those simply are not ready yet for the year 2014. But what we found is that 68% of Kentucky's rural hospitals scored below the national average on the Financial Strength Index, and a third scored low enough to be considered in poor financial health. The hospitals that scored below the national average served 838,000 patients last year, with the majority being on Medicaid or Medicare. The hospitals in poor financial health had more than 250,000 patients, and again the majority were Medicaid or Medicare. Although we did not take a comprehensive look at the circumstances surrounding individual hospitals, some common themes have emerged. 12 of the 14 hospitals that scored above the national average are owned or affiliated with a larger provider organization or are managed by a professional management organization. What we have found is that in several cases, these hospitals that have been able to affiliate with larger networks or form linkages are able to consolidate administrative operations to ease the increase in administrative burden that we have seen as a result of the introduction of managed care in Kentucky. That is significant. Rural hospitals that are geographically well positioned, such as the Pikeville Medical Center, scored high. On the flip side, those that are more geographically isolated, in particular the Clinton and Wayne County hospitals in southern Kentucky, scored low. These hospitals are vital to their communities due to their distances to large regional hospitals. Hospitals that seek ways to innovate are in a better position than they would otherwise be. And there have been some heartening examples of hospitals that are indeed innovating and doing things the right way to carve out a niche in a transforming landscape. Examples include the Rockcastle Regional Hospital, for example, which serves a small geographic community but has carved out a niche by providing ventilator-dependent care to patients with spinal cord injuries, genetic birth defects, COPD, and diseases like ALS. This hospital is only one of its kind in Kentucky and serves patients from across the country. Two rural hospitals, St. Clair and Highlands Regional, have joined a coalition to provide efficiencies, improve patient access, and adapt to changes under the Affordable Care Act. These are important hospitals to monitor going forward to determine whether this kind of creativity and innovation becomes a successful model for others to consider. Responding hospitals indicate on average 72% of patients receive Medicare or Medicaid benefits, meaning a significant number of low-income and elderly patients are affected in rural hospitals that cannot stay afloat. Folks, it is indeed historic and laudable that we have brought insurance to so many people in Kentucky who didn't previously have it. But if we don't make sure our provider network, particularly a network that is built around rural hospitals, is solvent, it really means that that insurance card doesn't mean much when you don't have people there to provide that care. And going forward, it is critically important that we bring together all the stakeholders and all the policymakers around a belief that rural hospitals admittedly have a difficult time managing this transformation. It ought to be the responsive role of government to monitor the situation at the granular level, to have a better understanding of what needs to be done in specific circumstances. Treating rural hospitals as merely part of a larger network robs us of our ability to drill down. It robs us of our ability to get beyond the vagaries of rhetoric. It robs us of our ability to solve specific problems by identifying specific challenges. And it is the focus of this report to provide a real sense of what the condition of the 44 participating rural hospitals are in Kentucky. Kentucky's government insurance mix is far higher than the national average, which is about 50% government, 50% private. The trend for this mix is expected to change to 75% government insurance and 25% private. This is especially troubling given that Medicare hospital payment to cost ratio is between 80 and 90%, and Medicaid was between 50 and 60%, whereas private payer sources, including commercial insurance, usually have a ratio of 150% of cost of service. Folks, that's a very fancy way of saying that government insurance reimburses below the level of care, and larger networks that are able to negotiate their cost do a better job of creating a business model that's able to exist. Smaller, independent rural hospitals do not have that economy of scale. So it matters a great deal when they have a business model that in the past has worked on very narrow margins because it assumed the presence of a healthy private insurance market. The disappearance of the private insurance market in many places in rural Kentucky is significant. Is a significant challenge to the long-term survival of rural hospitals in Kentucky. Let me use a couple of examples. In eastern Kentucky, where a healthy coal industry was occurring, resulted in private employer insurance for the people who worked in the mines or who worked for the coal industry. As we have seen that industry begin to disappear, you're seeing folks displaced from private insurance and moving to government insurance, those covered by Medicare and Medicaid, which is a positive thing. But we've got to make sure that everybody fully understands the implications of a disappearing private insurance market to the overall workability of business models for rural hospitals. When your business model is based on business model is based on a ratio that assumes a significant amount of your clients being covered by private insurance, which reimburses at above the rate of service, that helps you balance out your government-insured customers. When that disappears, it becomes very difficult to keep these hospitals open, and that's something that we've got to continue to work through. Hospitals that are financially struggling under the current payer mix and those who already serve a disproportionate share of Medicaid and Medicare patients will face even greater challenges as the percentage of private pay insurance declines and the DSH payments disappear. The loss of DSH payments will be significant to hospitals, even though prior to the phase-out they are receiving both DSH payments and Medicaid reimbursement for formerly uninsured, underinsured patients. So folks, as the DSH payment begins to phase out significantly over the next couple of years, that provides us in Kentucky a little bit of an opportunity to make sure that we're getting this right, to bring together all the resources we have in terms of talent and capital to make sure that our system remains and becomes more sustainable as we move forward. While much attention has been paid to the effects of Medicaid expansion and managed care have had on providers, it should be noted that Medicare patients make up nearly half of the payer mix. Planned cuts by the federal government in Medicare fee-for-service payments are already going to significantly impact rural hospitals. Already, penalties such as those for readmissions are having a negative impact on many of our rural providers. Hospitals with low financial strength index scores do not have capital reserves sufficient to withstand significant additional financial stress. Survey respondents reported to a range of $0 to $112 million of capital reserves on hand, which was reported as being sufficient to cover operations for a range of 0 to 245 days. I know I know many people who are in the policymaker space are making the case that all of the things that are happening in healthcare are good or all are bad for providers in the space. What is clearly happening is that some things are good and some things are bad. And a refusal to drill down, a refusal to continue to monitor the individual performance of rural hospitals robs us of a granular understanding of what's happening in the industry. And that's what we believe that we have to have going forward. A representative of one MCO reported that a small provider sought a cash advance from the managed care organization itself because it was experiencing cash flow difficulties. Low cash reserve balances may indicate weakness in a hospital's ability to maintain its facilities and equipment and its ability to withstand financial stress, such as late or disrupted payments from federal programs. It also poses financial problems for vendors who receive delayed payments from hospitals for services provided and jeopardizes a hospital's overall ability to make payroll. Administrative burden on hospitals have increased since the implementation of Medicaid managed care. Respondents reported that hospital administration costs have increased between $20,000 and $630,000 a year, which is an average of $156,795 in a total for all the respondents combined. It is clear that in our Medicaid managed care program, that the difference in policy and procedures and approach from the 5 different managed care organizations has resulted in a significant financial and administrative overhead burden falling on rural hospitals at precisely the time they can least afford it. Half of the respondents reported that administrative hours had increased by 26 hours more per week, which is difficult to meet when you're already on a thin margin. Additionally, more than half the respondents reported that it has been necessary to hire additional administrative staff and increase overtime to cover the additional administrative duties. When asked about the most significant reasons for additional time and cost associated with managed care, the most common responses were following up on denial of claims, increased pre-authorizations, and 5 different procedures, treatments from each MCO, covering each MCO. Also, providers have 5 different processes for the 5 different managed care organizations to be credentialed. Weaknesses in the contract between the Cabinet and the MCOs appear to be hindering improvements from being made to managed care in the Commonwealth and are likely contributing factors to the declining fiscal health of many providers. Auditors reviewed contracts between the Cabinet for Health and Family Services and managed care organizations and compared them to Tennessee's contract with their managed care organizations. Tennessee is considered a national model in the field of managed care. Auditors found several areas for improvement in areas such as strengthening penalties for contractual noncompliance, improving the Cabinet for Health and Family Services' ability to monitor quality and programmatic requirements, and improving transparency. When we sat down with the leadership of the managed care organizations, let me point out that managed care organization executives used words like loose and soft to describe the state contract under which they're currently operating. While strengthening penalties are part of the equation, so too are incentives for innovation that will lead toward improved health of Kentuckians. In our review of the contracts, we identified room for improvement in regard to wellness, accountability, and other areas that are at the heart of managed care that succeed over the long term improving the health of Kentuckians. The Cabinet for Health and Family Services must ensure a high level of transparency and accountability over insurance companies that ultimately are accountable to shareholders rather than our taxpayers. The Commonwealth's relationship with certain private vendors in the past, such as with present contractors, has demonstrated that problems arise when there is a lack of proper oversight. In short, folks, we can outsource the function, but we can never outsource the oversight and accountability that state government must provide in assessing the work of our vendors. The number of providers across the Commonwealth, particularly in rural Kentucky, dropped significantly between 2013 and 2014, raising concerns about accessibility at a time when more people are getting insurance. We found a decrease in providers in the majority of provider types. The following experienced the largest general decrease: general hospitals, physician groups, and individual physicians. Changes in total providers by Medicaid managed care region were analyzed, indicating a troubling trend. Rural Kentucky has been affected significantly more than other regions by a loss of providers. Regions in eastern and western Kentucky saw declines of 9 to 12%. By comparison, total providers in the central part of the Commonwealth decreased by between 1 and 3%. A decrease in providers, particularly in rural Kentucky, coupled with increase in members, creates additional health care accessibility concerns, which is the primary concern of this office, especially given the potential loss of additional providers associated with rural hospitals that already have fiscal stability concerns. The Cabinet is not properly monitoring, in our view, this decline, creating additional concerns that accessibility issues are not being addressed. So what should we do to monitor and address these concerns? The first is that we ought to monitor them. The Cabinet for Health and Family Services should begin in using an analysis tool to regularly monitor the fiscal strength of rural hospitals. Monitoring is important to ensure that the Commonwealth has sufficient information on hand to plan for and to attempt to prevent gaps in health care accessibility. It should closely monitor community access hospitals and other hospitals in poor financial health. A work group, I believe, is in order. Much to the credit of this administration, Kentucky was selected for a $2 million federal grant to test innovative payment and service delivery models. As part of this grant project, the governor has already convened a work group that should examine, among other objectives, new models for rural health delivery to ensure quality care and continued access in the altered healthcare landscape. It should closely examine hospitals in poor and fair financial health and evaluate solutions such as affiliations, mergers, management agreements, networks, and other opportunities to innovate. And it should evaluate whether Kentucky's current regulatory structure gives hospitals the flexibility to retool their business models for 21st century healthcare delivery. This group should consider, for example, whether the regulatory structure permits hospitals that have underutilized costly inpatient beds to cease or scale back inpatient care and focus on emergency services, outpatient, and other specialty care instead. It should evaluate the effects of recent changes to the Medicare program are having on rural hospitals and explore strategies for hospitals that are being hit with costly Medicare readmission penalties and hospitals that have acquired penalties that should try to reduce those rates. It should assist in addressing workforce adequacy issues, including expanding scholarship programs, establishing programs to identify potential in-state medical students earlier, enhancing recruitment and retention efforts in the medical field, and other innovative solutions for enhanced recruitment and retention of healthcare workers. It should examine other issues related to rural healthcare access, including emergency and non-emergency transportation, and the role of public health departments can play in this altered healthcare landscape. The Cabinet for Health and Family Services should work to improve relations and particularly communications with providers, particularly our small rural hospitals. The Cabinet this year has an opportunity in the next several months to really go a long way towards addressing many of the issues that we have uncovered in our nearly year-long study of this effort. I cannot stress how important the renegotiation of the MCO contracts is. That's to be finalized in July. But making sure that we have contracts that are stronger, that have real teeth, that do a better job of ensuring that our MCOs and provider community are working on the same page rather than at cross purposes is incredibly important. And I should note that we have been in substantial conversation for an extended period of time with the Cabinet about how they can improve the contracts under which the MCOs are operating. And while the proof will be in the pudding later this summer, we are pleased and are optimistic that the current work of the Cabinet to strengthen those contracts is going to bear real fruit. But to be clear, we believe that the Cabinet for Health and Family Services should establish a uniform credentialing, re-credentialing process for the MCOs, making sure that our rural hospitals get to operate under one standard of approach in the relationships with the managed care organizations. There ought to be contractual penalties that should be strengthened, such as listing specific penalties and establishing criteria for applying those penalties, and that there ought to be quality reporting that ought to be expanded in order to assess the performance of this critically important system. And when you want to know how important Medicaid is to Kentucky, consider for a fact that it is our second largest expenditure of state government. Folks, we cannot afford to be asleep at the switch when it comes to monitoring a program that is not only represents an extraordinarily large investment from American and Kentucky taxpayers, but also represents an important path going forward to making sure that Kentucky can reverse its path of being one in which we are best described as having truly terrible health outcomes. So if I'm asked to bring all of this together, what does 9 months worth of work by my Medicaid Accountability and Transparency Unit, what does it mean? It means that we have a tremendous opportunity in Kentucky to improve what are really terrible health outcomes. But it is not going to happen organically. The system we've got in what is clearly the most transformative environment healthcare has seen since the introduction back in the 60s of Medicare and Medicaid is one in which all stakeholders are going to be involved, and that we're going to rely on information being available that helps us guide that, because big pie-in-the-sky arguments about ideology don't do anything to keep the hospital network in Kentucky sustainable. What we need to understand at a grand level is the unique challenges that our rural hospitals are facing And then we need to bring the best and brightest minds together from all across the Commonwealth and the space to find specific solutions for these specific problems. Doing that and strengthening the MCO contracts will go a long way to making sure that the strides we have made in the last couple of years in the healthcare space are themselves sustainable over the long term. An awful lot is depending upon it, and I'm going to do my bit as long as I'm in public life to make sure that we get it right. Thank you for the opportunity to do this very important service on behalf of the taxpayers. If anybody has any questions, I'm happy to answer them.
I think I counted 14 that did not cooperate.
Sure.
Does that sound about right?
That's about right. So there are 66 rural hospitals in Kentucky. There are 44 that cooperated in this program, but keep in mind there are another 8 that are affiliated with larger networks. For instance, ARH, which was a tremendous supporter of this project and making information available to us, represents 8 different rural hospitals. So of the 66 that are in Kentucky, we have substantial information on 52 of them, and those who chose not to participate in general tended to be the privately run for-profit hospitals, and it's just a different approach.
Since we don't know their financial health, let's say all of them are in excellent health, would that skew the
Not at all, because remember, that's a great question. Let me speak to why that's so important. Because there is a tendency among policymakers to say that that when we look at a new initiative, that it's either all good or all bad for hospitals or people in that space. For instance, the debate about the Affordable Care Act in Kentucky is one that I think speaks to why the model for fixing problems in Kentucky is broken, because you have one side saying it's terrific, it's improving the condition of all hospitals. You have the other side saying it's a terrible thing and it's diminishing the sustainability of hospitals. The truth is, unless you get in at a granular level and understand what is happening at each rural hospital, you get lost in a larger argument. And what this is about is providing an assessment of where we are at the granular level, because these different hospitals are unique and they have different sets of challenges. There are certainly going to be a number of hospitals whose position have been significantly helped by all the new policy initiatives that we've had. There are going to be other places where they have challenges that are so unique to them that we have to have a more complete understanding of what is happening at the local level. So at the end of the day, this report is about localizing the issues in the healthcare space and understanding the problems and being able to identify them at the granular level, rather than a whole system getting caught up in a much larger conversation about issues coming from Washington.
When it comes to rural hospitals, it seems like most of the problems that they have come from the Affordable Care Act and the managed care. I mean, how is that not a rebuke of that?
It's not. I think you've got it wrong, because this report doesn't speak to causation. We don't get into that. The largest contributors to the difficult position that rural hospitals tend to be in is, I'd say, the number one overall issue is a challenging local economy. When you see a disappearance of private insurance and a heavier utilization of government insurance, your former business model has to be transformed. And I would point that it is much better for a hospital to have patients that have some kind of insurance rather than no insurance. And to speak to managed care, I don't think anybody thinks that we ought to scrap managed care in Kentucky. Clearly, we couldn't afford the old fee-for-service model because the impact it was having was bankrupting the Treasury. But what we have an opportunity to do, particularly with strengthening the contracts we have with managed care, is smooth the rougher edges of managed care. Make sure that we have a system that is running exclusively for the benefit of patients, providers, and taxpayers.
Did you get a sense as to why providers are leaving? I mean, is it folks retiring, or is it too burdensome to continue under the new rules, or what?
All of those things. I think we're having an issue in Kentucky. I think we still rely on a recruitment model when what is, I think, more effective in forming a sustainable number of providers is a pipeline model. You want to keep someone in rural Kentucky. You want to recruit someone to rural Kentucky To me, I think the better approach is to identify rural Kentuckians at a young age who have a talent that lends itself to being a healthcare provider. You know, Happy Chandler said he never met a Kentuckian who wasn't coming home. I think we need to do a better job of identifying promising high school students who have the potential to serve their community in the healthcare space, making sure that they have the resources to do precisely that and then come home and take care of their local communities.
You mentioned the work group meeting to look at the flexibility of the current certificate of need process to see if was the feedback you got from hospitals that flexibility is not there right now, that they can't switch quickly enough?
We've certainly heard that, and there are specific issues given to individual hospitals, and what we want to make sure is that there isn't a one-size-fits-all approach to how we create sustainability with rural hospitals. This is awfully important that we have the flexibility in our current policies and procedures that provide for exactly the same kind of freedom to innovate that these hospitals are going to need to survive. And make no mistake, the whole landscape has changed. Rural hospitals cannot survive under their old business model. They're going to have to change the way they do business. Government needs to be in the business of facilitating that innovation rather than retarding it. And I think there is a tremendous opportunity going forward with the cabinet. It's worked through the work group that the governor has convened. And I do want to give some credit where it's due. I think the cabinet is currently reviewing all of their approaches to make sure that they are able to foster the kind of innovation that we need to create a sustainable network in Kentucky.
Well, the cabinet has been, they've rejected your suggestion that it should become a financial monitor.
Right.
You've got 1/3 of these hospitals, maybe 1/4, that didn't want to cooperate and they're primarily privately owned. Looking ahead to the next session of the legislature, do we need a law that empowers the cabinet to do that, or that requires the cabinet to do that?
We very well may. When I'm asked what can the cabinet do in the short term to create a more sustainable system in Kentucky, my immediate answer is that we have got to strengthen the MCO contracts. If I had a level of expectation from the Beshear administration, it would be that they do that in the next few months. And I do have some confidence that they're on this path. I'm less concerned by the rejection of this administration in monitoring than I am in trying to make the case to the next administration that we have got to monitor this system, because refusing to drill down robs us of the ability to understand at the granular level what's occurring. So I'll be making the case to all the candidates for governor that their administrations should commit themselves to monitoring and fully understanding the financial health of each rural hospital in Kentucky. And if that means legislation, then that means we may go with that approach.
Do you think that law should require or simply enable the cabinet to do that?
I would prefer to see a cabinet, Al, I would prefer to see a cabinet willingly take the bit, but if they don't, we'll go a different path, and I reserve the right to do it myself if the next governor won't. I really think that if we're going to solve problems in Kentucky, it helps if we get out of ideological battles, ones that are viewed through a partisan prism, and focus on what the actual condition of is at the local level. And in healthcare, you cannot fix and create a sustainable network of rural hospitals if you don't understand the individual condition of those rural hospitals. And this ought to be a tool for doing precisely that. And I understand this administration has other priorities, but I think the next administration is if they're serious about creating that sustainable network of rural health care, has got to commit themselves to understanding it again at the granular level what the condition of each rural hospital is in Kentucky.
So I understand you don't have audited 2014 information, fiscal year 2014 for all these hospitals, but you got it from 2, right?
We do.
And my question is, in those 2 cases, whatever new money came in from ACA didn't help them.
Well,
one went down.
One slightly improved their position, the other
but
didn't.
We're still poor, right?
Correct. But I want to point out to you that I have to be very careful about protecting the integrity of the numbers. And I'm not sure that 2 hospitals from 44 is representative. And I think it's in the best interest of everyone who wants to make a positive contribution to this discussion that we wait until the coming months to have a better understanding of really what the impact has
The
been.
question is, we shouldn't extrapolate anything from those two that you did get,
No,
right?
sir. No, sir.
Were you surprised at the extent of the cabinet's response?
Well, I think the Cabinet has a lot that they should be proud of. I think the Cabinet is driving a level of innovation through Connect and Medicaid expansion that is a record that they should be proud of. It represents the most serious attempt to address Kentucky's pitiful health care outcomes that I think we've ever seen in Kentucky. And I certainly do not think that there is anything in this report that ought to detract from the very good work that's being done. The question is, what are we going to do going forward? And I think it's very important that we commit ourselves to monitoring in order to get granular level understanding of what's happened in rural communities. And beyond that, having some kind of work group that's focused on addressing what those individual issues are. You know, I think that's where this thing's got to start and finish.
You say work group, the release said task force, is that your preferred term now?
Either one is all semantics. I just want really smart people getting together to make sure that we don't give up on rural health.
And is that something different than this the effort funded with the $2 million grant?
I don't think so.
Okay.
In our work is that this is a terrific opportunity to dovetail what we recommend with what the administration has already laid out as their function. Okay. You know, I'm not. When you're in the business of counting beans in a state that doesn't have a lot of beans, this is a real opportunity for us to dovetail those missions. And it's my hope that the administration, in its remaining months, will build that infrastructure to make sure that continues. But if they don't, I'll be aggressive about pestering the next administration to make sure that they do. And if that administration refuses to monitor, then we'll do it ourselves right here in the auditor's office.
How do you separate a report like this from politics in an election year, given that it touches such a charged issue like the Affordable Care Act?
Well, I think this is important because our work here, even in a political year, generates more light than heat. And I think the discussion about health in Kentucky has been all about heat and very little about light. And I think the best disinfectant is sunshine. And I think understanding really what our challenges are down to the granular level really does more to get politics out of it. Because I think politics is allowed to grow best in Washington and here in Frankfort. What we're trying to do is get an understanding at the local level of the specific challenges that specific hospitals are facing. And make no mistake, this just isn't an issue for those who represent us in Washington and Frankfort. Local communities, chambers of commerce, business leaders, physician groups need to be taking the results of our work and trying to fully understand why their hospital is in the condition that they are in. Folks, this just isn't about health care. Let me be crystal clear. This is about whether we are going to give up on rural Kentucky. Because if you think that this is just going to get better, and if you think that we don't have a hand in making this sustainable, and we permit this entire network to disappear, what you're going to do is create a class system in Kentucky. And those people who live in rural areas like my family and the one I was born to are going to have an inferior level of care and therefore an inferior level of quality of life to those who live in more urban and prosperous suburban areas. And that's just not right. Making sure that we have a sustainable network of rural hospitals and the healthcare network that they support is critical to making sure that we have prosperity in every corner of Kentucky.
As a follow-up to that,
yeah.
Don't know if you know, Jamie Comer had a press conference today about 10 o'clock, about an hour ago.
Yeah, I'm thrilled y'all are here. Thank you for coming.
But part of this press conference on his health initiative was endorsing a part of this audit that hadn't yet been released. Do you think that he in any way undercut you today as far as...
Well, we certainly didn't give him a copy of the report. I understand, but I've been talking about this rather expansively so I can see how things have been pieced together. But no, I mean, I'm not going to be, listen, pal, I'm not going to look at this cynically. An endorsement of this report by a member of the other party is significant. And I suspect that when other candidates for governor who have the opportunity to see the work, which we'll make sure we do today, my guess is that they'll follow suit.
You mentioned the collapse of the private insurance market in some areas as
Sure.
being a big reason for some of the poor financial health here. Is that related to the Affordable Care Act?
Not at all.
More people go into Medicaid?
No, it's related to a down economy. People who are employed have insurance. Generally, people who are employed generally have private insurance. People who are not do not. And what has happened in Kentucky is that as we have seen rural industries particularly impacted, coal, large agriculture, private agriculture operations lay off their employees, they're losing private insurance. And that's most acutely felt in the East. But no, I don't think it's fair to blame the Affordable Care Act for a very slow economic recovery, if any recovery at all, in rural Kentucky.
This issue of the number of providers, the cabinet seems to dispute that. Is that an apples and oranges issue there?
No, let me point out both numbers have been provided by the cabinet.
I mean, it just sounds like, are they counting something different than?
Well, what in the area of providers, what they count is a much smaller population of paid providers. Okay, that is an assessment that is what it is. Our assessment is based on a larger group of eligible providers. And I think why this distinction is so important is because when you insure 400,000 new people, which is both historic and laudable, you have to have an increase of providers to be able to ensure that care is available. So this really is about accessibility. And going forward, monitoring is critical because you've got to know what you're dealing with, particularly when we've reached 400,000 new people.
You've got 14 red dots up there. How many are really at risk of closing in the next 2 years?
That's a good question, Al. We know that there are 14 in trouble, and what we know now is that we have the ability to drill down and understand even beyond where we are who really is in trouble. In the past, we being state government has either relied on press reports or anecdotal information to paint a picture, to create guesswork about who's really in trouble. Now we've got a specific number list, and I can't tell you who is of the 14 that are in the poor category.
Anybody else in bankruptcy but Columbia and Albany?
Not that I'm aware of.
Is it realistic? I mean, if nothing changes, is it realistic to think that some of those red dots could close in the next couple
Sure,
years?
and I think that, and let me point out that this isn't merely a Kentucky problem. This is a national issue. I think since we passed the Farm Bill, this is the most important issue facing rural America. That is the sustainability of rural hospitals. And in every state in America that has any rural character at all, they're dealing with these issues. What our hope is, by drilling down, we can provide a Kentucky solution to what is truly a national problem. And moving forward, I hope that the information that we are producing and have committed ourselves to continuing to produce will help policymakers have a better understanding of what's happening in specific communities in Kentucky.
Well, the biggest problem nationally is among the states that didn't expand Medicaid.
Correct.
And the rural hospitals are caught in this horrible bind. I imagine that some people will probably use your report as an example of, hey, Kentucky's supposed to be this great example, and yet here's the auditor saying that rural hospitals are in trouble partly because of the Affordable Care Act. Would you have any advice for states that haven't expanded Medicaid, whether or not they should or shouldn't expand it for the sake of rural hospitals?
To the extent that I can offer advice to anybody outside Kentucky, my advice would be that you ought to expand Medicaid. That over the long term, its promise, I think, significantly outweighs. I think its promise significantly outweighs its difficulties. Over the end, I think it is impossible to argue that it is cheaper over the long term. I think it's important to argue that it's cheaper over the long term to have people insured rather than not be. And for those who want to use this as fodder to attack the ACA, I don't think that's fair at all, because keep in mind, this is a baseline that is post-introduction of managed care, but it is pre-implementation of the Affordable Care Act. So this gives us a base from which we can evaluate the performance going forward, because it is, anybody who spent 15 minutes in the private sector will tell you if you can't measure it, you can't manage it. This is the measurement tool going forward that we have to have. And Al, I just come from a school of thought that opinions ought to be based in fact. Anyone else?
Thank you.
Thank
Thank
you.
you.